Just going to give everyone a few minutes to load on and get all their audio and visual ready to go. I hope everyone's having a great morning or afternoon for some of you. Let's see. All right. Well, it's 12:02. Thanks for joining everyone for this afternoon presentation. My name is Michelle Jew. I'm the program coordinator with Aspire and Appeal. This is the Diversity and Inclusion series entitled Creating a Culture of Respect for the Asian American and Native Hawaiian Pacific Islander Community. We have two great featured speakers with us today, one being the Dr. Janice Tsoh. She's a UCSF Professor of Psychiatry, and the other being Dr. Andrew Subica. He's a UC Associate Professor of Social Medicine, Population, and Public Health. Next slide, please. So today, we're going to be covering these three objectives, those being increasing a positive health-seeking behaviors through providing culturally sensitive education for tobacco and cancer, as well as creating a safe space and providing community wellness through a lens of cultural respect and humility when we discussed about the topics of tobacco, cancer, and culture. We're hoping to provide you with some resources and information about being culturally respectful in tobacco cessation and cancer prevention for our Asian American and Native Hawaiian and Pacific Islander communities. And next slide. Really quick, our agenda, we'll do some housekeeping and then I'll introduce our speakers. We'll do presentations from both. And then we'll open it up to a panel discussion and Q&A, and then close with some closing remarks and an announcement about our evaluation survey. Next slide. So some webinar housekeeping. This is a webinar format Zoom call. Your video and mic is off throughout the webinar. You may ask your questions for speakers by clicking the Q&A icon on the bottom and then clicking to all panelists and attendees. If there's any comments to speakers, please drop those into the chat box and we'll be monitoring that throughout the presentations. If you have any other tech questions or technical support team, Josh and Jess are here to help you on this call. So please give them a shout if needed through the chat. The webinar will be recorded. We'll be posting this on our designated program websites for participants to view. Thank you for your cooperation, and we're hoping to make this an excellent webinar for both us, the speakers, and the community. Next slide. Okay. So our featured panelists for today's webinar, we have Dr. Andrew Subica here with us. He's the Associate Professor of Social Medicine, Population, and Public Health at UCR School of Medicine. He's a faculty member. His research targets the mental health and physical health disparities affecting vulnerable populations. And he really uses these perspectives of health equity, social justice, and community participation to do a lot of his work. And he has a special focus on addressing health disparities that affect the Asian American, Native Hawaiian, and Pacific Islander communities. Next slide. We also have joining with us Dr. Janice Tsoh. She is a professor of psychiatry and behavioral sciences at UCSF School of Medicine. She's a clinical psychologist by training, and she works as a professor of psychiatry and behavioral sciences. She serves as a co-director of the Asian American Research Center on Health, also known as Asian ARC. And her research focuses really on reducing health disparities through lifestyle interventions. She would like to promote smoking cessation, physical activity, and healthy eating, targeting Asian Americans and other vulnerable populations as her main research points. Okay, and next slide. So with further ado, we'll actually start with Dr. Tsoh, and please join us on our socials if possible as well. Okay, and I'll pass to Dr. Tsoh.
All right, good morning and good afternoon, everyone, and welcome again. So glad to have this opportunity to see you all and to start this conversation. Is my pleasure, to also partner with Dr. Andy Subica as well. And so I think our plan today is that we're going to have the two presentations and Michelle just mentioned. And so I will take about 15 minutes or so. I will try to say I have a lot of slides to share, but I will kind of jump from one to another just to have us to stay on time, around 15 minutes or so. And then Dr. Subica would be your turn to present, and then we hope to launch into conversations among all of us. So I hope this sounds like a good plan for today. So give me just a second here. Let me just start us off with the slide here. Okay. All right. So again, I mentioned about we're going to have a very quick ride for mine. I'm very greedy, including a lot of slides here. But I think importantly, we really like to start us off with a conversation about diversity, inclusion, and importantly, creating a culture of respect, particularly when in the topic of tobacco and cancer health related disparities and how do we engage our community. So my part is going to focus on Asian American. Providing you a quick snapshots on some of the current landscape of tobacco and cancer-related disparities in Asian Americans, and also examples, some very selected examples of opportunities to engage. And I'm sure all of you have also various experience, so we're looking forward to hearing your insights and experience as well. Just starting us off is I'm preaching to the choir here, but we know Asian Americans, very diverse group, is the fastest growing population and currently constituting 7% of the total population. The diversity is amazing. Talking about more than 50 cultural, ethnic, Asian countries of origins, and also speaking over 100 of dialects and languages. And when we think about this diversity, it becomes some challenges when we're talking about how can we engage our various communities. Back to our topic, cancer is the leading cause of death in Asian Americans, whereas other racial ethnic groups, heart disease usually. Let's start us off with tobacco-related health disparities. What are the tobacco use prevalence? My go-to place is usually CDC, MMWR, and you can see this is pre-pandemic data here. But usually what you will see is they will say, the lowest tobacco use or the lowest smoking prevalence is in Asian Americans. Is this the true story here? Okay, so I'm going to show you and let you think about it. So some of the numbers here, if you look, is like any tobacco products, 11%, or cigarettes, focus on combustible cigarettes, 7%, under 10%. Like Asian smoke, really? Yes, take a look at this data here, talking about combustible cigarette use across Asian Americans, including a combined Native Hawaiian Pacific Islander men and women. Look at these diversity and differences. The reason why the MMWR table didn't, or actually it did not present a full picture is because, number one, we have a lot of subgroup differences. As you can see, both the blue and the purple bars here, but also you could see that there's a huge difference between men and women tobacco use. So when you combine the data, looking at those very low rate, this is definitely not the full picture. And you can see, a lot of bars above this dotted line, whether it's among Asian Americans combined or, general Americans. Talking about language, that is another area that's often overlooked. In our Asian American communities, we have, depending on which group, right? I'm talking about aggregated data, even though I'm really advocating for disaggregating data here. Some of the Asian men who speak limited English, that's where we see a lot of high smoking rates. you can see the darker green bars there, looking at the higher, particularly higher rate than who are speaking limited English as compared to those who are English proficient. How do these get translated to cancer mortality? This is a very important article just recently published, and it's highlight various cancer death data based on death certificate. And the researchers summarize according to tobacco related all the way to infection related. If we just look at tobacco related, comparing between foreign and US born individuals, that's where we see some of the mortalities. Now, remember the slide I just showed you here, right? Some of the differences in some of these select groups like Chinese, Korean, and Vietnamese group. How do these data get translated to cancer mortality? Looking at these foreign-born Vietnamese, Korean, Chinese, a much higher rate of tobacco-related cancer. Okay, how about cancer health disparities in general? Many of those affected by tobacco use as well, but many of those aren't. Also, looking at some of these numbers, just a quick snapshot of this, talking about new cases. Asian Americans just in general, across all group, you would see 20% of the new cases of prostate cancer among men, and then about 1/3, 33% would be either of these one of the three: a lung, lung, colorectal, or liver. When we look at female, about 35% of new cases breast cancer, and roughly 1 in 4, 24% would be either lung cancer, colorectal, or uterus cancer. Liver cancer. Liver cancer is one of those that Asian Americans have a higher incidence, significantly higher incidence when compared to other racial groups. So as you can see for these different color bars here. But if we're going to go into subgroups, into different groups, that's where we see a lot of high rates there and very different rates. Stomach cancer is another one where Asian Americans have higher rates, and we need to talk about which kind of stomach cancer. And among non-cardiac, depending on the location of the stomach here, Korean, Vietnamese, South Asian, and Japanese, they're all high up there as you look at the race as compared to Hispanic, Black, and white American. And certainly not all Asian Americans have high rates. For example, Filipinos have still a higher rate than non-Hispanic white, however. Another look, emergent evidence. You may be paying attention to this more lately. Many people think of lung cancer, related to smoking. We have a lot of non-smokers getting diagnosed with lung cancer. 57% of Asian American women diagnosed with lung cancer have never smoked. Look at these rates across here. This is really, really important when it comes to understanding and the need to understand what may be going on about these rates as compared to, Black, Hispanic, and particularly non-Hispanic whites in terms of the proportion of non-smoking women who diagnosed with lung cancer. So this is another area of disparities that we need to pay attention to. Screening is another area. We all know that early detection. Screening is very, very crucial when it comes to survival rate. And these are some of the disparities where Asian Americans have a higher rate of non-adherence to cancer screening guidelines. And it's even more so, as an example, if we take age into factor. Here, again, we're talking about combined, across group, not disaggregated data, but nonetheless, this is pretty obvious when we talk about this picture. Look at these rates across colorectal, breast, cervical, and certainly the highest number of Asian American women here in this age 65 and up did not have screening. After screening, we're talking about aftercare, right? Follow-up. Here are the examples where some disparities coming on, where we've observed some Asian women after, having an abnormal mammogram did not get follow-up. At least they did not get a follow-up in a timely manner. Filipino women, Vietnamese women, they had a longer days lapse, like in terms of time following their abnormal mammogram. And actually, a significant portion of Filipinas did not have follow-up at all in this study. Bringing us back to the cancer mortality rates in terms of examples of the nativity, how that also being affected across the line of number of tobacco related, screening related, diet obesity related, and infection related, there where we see a lot of disparity, particularly among those immigrant population. Now, once again, these are purely selected snapshots. Survivorship, quality of life. An article published in 2021 is really even up till this day how cancer stigma can impact on our community among Asian Americans. The survivor, for 28 years, I kept my breast cancer a secret. I lived in fear that my Chinese American friends would shun me if I told them that I had endured. Some opportunities, I'm watching my time closely here, not to take too much of a time like me talking, but wanted to involve you all in the conversation. Also, Dr. Subica's important presentations coming right up. So share with you some just purely examples of engaging our community perhaps from clinical settings, from medical settings to communities. Some examples. Well, starting off with tobacco, actually, we have very good resources. Now, not perfect, but at least it's cover some of the most frequently used Asian language, Chinese, Korean, and Vietnamese, available through Asian Smokers Quit Line. It worked. It worked when the person called, but just like National Quit Line is heavily underutilized, and we need to have a way to bring people to use the quit line. Primary care setting represents a very important and unique opportunity. Unfortunately, less than half of the Asian American smokers did not receive advice from their doctor. We all know lots of barriers there. And our team have addressed this by how about, okay, when they come to see the doctor, we actually slip in a tablet, an iPad or Android, and to have them do an interactive video education to see if that could increase discussion with their doctor about tobacco use. And then we say, yeah, our initial outcomes show that they increase discussion as well. So this is just like an idea of some of the interactive video education following the guidelines. And currently it is in English, Chinese, Korean, and Vietnamese. And when we engage community, we really need to engage our key informants, community advisors, and some of this quick finding that when participants receiving the IMD program, they were much more likely to receive a discussion with their doctor as well, and also that they were more satisfied with the discussion with their doctor. However, quitting is very hard. You could see, even though we got a statistical significant, this is relatively still a smaller sample with 130 completed and intention to treat with 170 people. 9% of people quit in 6 months, so we can do better. A lot of room. Another example of video education for hepatitis B and C promotion in clinical setting. This one is really getting a very good impact here. As an example, here in multiple language, in communities, our team used a lot of lay health worker peer-to-peer outreach, colorectal cancer in multiple groups, for example. And then we also expanded it to work with smokers and their family, where we actually get to work involving both of them. We have tobacco focus, we have another group focusing on promoting healthy eating and physical activity. So we have published some of these works here. Some of the materials, we call it flip chart. This is pre-pandemic when we were in person, although I know that we will be in person very shortly. Some of these materials are available for you to modify and use with your community. Some of the snapshots of this, talking about addiction, this, people don't feel comfortable using a nicotine patch or gum or some of the FDA approved medication, but we need to teach them about addiction. So, about e-cigarettes, family relationship is another one that we actually talked about. This is in Vietnamese, and you can see this is actually the backside of the flip chart. It's like a menu is a hard copy of a PowerPoint presentation. That's what we use in some of the materials for the lay health worker, because they're not professionally trained. I mean, they're trained by us as professional, but they are peer-to-peer outreach. So they have these materials that they can use. So talking to the family, creating a respectful, socially and culturally appropriate space for them to talk about tobacco use. Not everyone are ready to quit, and we accept that. But there's just something everyone can do to improve their family health. So I'm going to kind of jump, some of the slides here, as these are just some of the materials that you can see. And today we have worked with more than 1,200 individuals, and many people quit as a result. So we're very happy with that also. This is a new ongoing study. It's not focusing on cancer. Nonetheless, I just want to show an example of kind of slipping in some of the, tobacco-related messages here. Tobacco users, they are more likely to get severe COVID, and why? This is how we engage our participant in a COVID-19 focused education program, where we actually use our Healthy Family project model. And we got engagement. We send them a text, they text in, and there we go. And they actually talking about their thoughts about tobacco. And lastly, one of our ongoing, actually just completed study on cancer care support here. And again, we utilize some technology and also telephone telephone navigation as well, navigator, to support cancer patients in their journey while they're receiving treatment. We got very good feedback there as well, and very appreciative. I think we have a lot of work to be done, but just to sum it up, we have opportunities. Some of these, not limited, we're using, leveraging these. We have health system, we have community, social networks, certainly technology, and we can work together to address these health disparities. Importantly, I feel that it's also important to bring the interventions, the services, the resources to where the people are. So thank you very much for your time, and looking forward to more discussions today. So we will have Dr. Subica next.
Sorry, I wasn't sure if Michelle was going to jump in. I mean, that was awesome. You set a high bar. Actually, you went really quick. So I guess for the entire audience here, I will try to go equally quick through my slides so we can get to this panel discussion. So what was wonderful about what Dr. Tsoh talked about, which was primarily on Asian Americans, so that I could then talk a little bit about Native Hawaiian Pacific Islander cancer and tobacco research, was that she had so many examples of this great body of research that's been done, and hopefully everyone can see this. The challenge with Native Hawaiian Pacific Islander cancer and tobacco research is that just the research and knowledge lags behind pretty much every other US racial ethnic group that we have. And this includes Asian Americans. So I will talk about some of the success stories that we have within the research field in this area, but it's nowhere near this kind of litany of projects and papers that Dr. Tsoh was able to put up there. As a result, though, of the fact that we just have less research. Oh, and there's a chat thing. Thanks. Okay, we know less about Pacific Islander cancer than pretty much every other racial ethnic group in the US, including Indigenous American Indians, Alaska Natives. We have a much stronger body of research with other Indigenous colonized communities, populations in the US versus Native Hawaiian Pacific Islanders. And let's see. So there are several reasons. I think most of the people on the call know this. First of all, Pacific Islander population sizes are relatively small, so they're hard to capture in these health surveys, including the California Health Interview Survey. Of course, we know for decades that Pacific Islanders have been mistakenly aggregated with Asian Americans. Dr. Tsoh talked about how that actually suppresses potentially the disparities that Pacific Islanders experience. And then there are understandable challenges engaging Pacific Islanders in health research. I experienced some of this in my own work, and this is completely understandable. There is a healthy cultural mistrust in many Pacific Islander communities. There are language barriers, and quite frankly, many of the research methods that we use as a standard kind of application of this, they're just not culturally responsive for Native Hawaiian Pacific Islander communities. I would be remiss in not talking about the fact that Pacific Islanders just have profound health disparities across the board. If you look at nearly every chronic health condition that you could find, obesity, diabetes, heart disease, stroke, cancer, Pacific Islanders have disparities relative to the US general population. And this includes now in some work that we're doing severe disparities in mental health and substance use disorders. But why is this the case? I have to at least bring this up. The fact that health disparities began after Western colonization of Pacific Islander peoples. So one example, very famous, is in Hawaii. Prior to Western colonization, there were over 700,000 Native Hawaiians who were living in Hawaii. By the 1900s, after colonization, there were less than 24,000 Native Hawaiians living in their ancestral homelands. As a result, because of this post-annexation oppression that Native Hawaiian Pacific Islanders continue to experience today, Native Hawaiians have lower incomes and education. They're more likely to be living on the streets or unhoused, more likely to be incarcerated, uninsured, and have much poorer healthcare access than other populations in Hawaii. As a result, Native Hawaiians now have the shortest lifespan of any racial ethnic group in their own homelands. So that is one big thing, I would want us just to consider, is this cultural historical trauma and how it's perpetuated. And this leads to things like Pacific Islander peoples being at elevated risk for cancer. So top 3 cancers in Pacific Islander peoples are prostate for men and breast cancer for women is number 1. And then lung and colorectal cancers for both genders. Tobacco-related health disparities, something Dr. Tsoh talked about, they account for about 60% of all Pacific Islander deaths in the US, with lung cancer being the top driver of cancer mortality in Pacific Islander peoples. The other one for men is liver cancer is the leading cause of death. So Samoan and Native Hawaiian men, and again, there's not a ton of research, but Samoan and Native Hawaiian men, they're the 2 largest Pacific Islander groups living in the US. They're about 8 times and about 2.5 times more likely than white men to develop liver cancer here in the States. For women, lung and breast cancer are the leading causes of death. As a result, Pacific Islander women have 41% higher overall cancer mortality versus white women. And this includes for cervical cancer, they have about 2 times greater mortality rates versus white women, and then breast and endometrial cancer. So one thing that's interesting, and I'm not sure how much this has actually been looked at for Asian Americans, so maybe we can talk about this a little bit, Dr. Tsoh, is there's some research that suggests that Pacific Islanders may have these unique biological factors that actually increase their risk for both developing cancer and passing away from cancer. This includes more aggressive tumor growth in certain Pacific Islander populations and patients relative to other racial ethnic groups here in the US. For instance, one study that was done in New Zealand found that Maori and Pacific Islander participants living in New Zealand, they had larger breast cancer tumors, higher grade tumors, and when their cancer developed, more involved lymph nodes versus general population of New Zealanders. Of course, one of the things that's driving this is that there are a number of treatment barriers to both cancer diagnosis and treatment for Pacific Islander communities. Number 1 is lack of knowledge about cancer. This ranges from screening to cancer risks, to symptoms, to treatments and prognosis. There's something, and I see this actually a lot even in my own work with communities, is there sometimes is a fatalistic belief about cancer that can emerge in these communities. But really the main driver appears to be lack of access to just cancer care. Pacific Islander communities, for instance, in California, have among the highest rates of uninsurance. in the state. And then many Pacific Islander communities living in Hawaii and the continental US, they live in these rural areas that don't have much access. I'm from the Big Island. And so for people to get adequate cancer care, diagnosis screen, they often have to be flown to another island in order to receive that care. And then once people do get care, get good services, really they tend to be not culturally responsive, which can lead Pacific Islander patients to drop out of treatment. As a result, Pacific Islanders typically present for treatment at these later, harder to treat stages of diseases, and this may be driving this disproportionate mortality that we're finding. But I really want to highlight some successes. That's really the kind of context for this study, this presentation. So the first one I'll talk about is something called Ho'okele Ikeola, Navigating to Health. And this is a 48-hour curriculum to train cancer navigators to kind of reduce these barriers to cancer treatment for Pacific Islanders living in Hawaii. This was funded by Imihale, which was funded by the NCI, led by an organization called Papaola Lokahi. But here's the interesting thing, is they developed this curriculum using what's called community-based participatory research process, which I've come to believe is one of the main ways that you really have to do good sensitive research with Native Hawaiian Pacific Islander communities. So they did this step-by-step process. First, they did interviews with outreach staff and providers. They took this data and they allowed this to inform their follow-up discussion groups with cancer survivors and family members. And they went to 5 different islands to capture important data about cancer navigators. Then they did these surveys with outreach workers and family members, while receiving technical assistance from a National Cancer Navigator program in Denver. And here's what they found I want to talk about. When they talked to these different stakeholders, they found some very interesting themes. First, that it was seen as a death sentence when somebody got cancer in some of these communities. And this often led to intense anxiety when they were waiting for their biopsy results, when they were waiting to get treatment or be transported to a different island for treatment. Doctors would provide a menu of treatment options that participants were happy about, but they didn't give them enough information to actually make good treatment choices. And patients and families really wanted navigators to teach them about cancer, help them access these services, including insurance, and then connect with support networks through the entire difficult process. And one thing that was interesting was a lot of participants stated that they were concerned about being seen by doctors, nurses, and even the navigators as being stupid or burdensome by asking very simple, important questions about their care, about their cancer. So that was seen as a potential block that they wanted navigators to help them with. So there were 3 areas that cancer navigators had to be trained in. The first was major cancer tests, side effects. So really knowledge was the key. Then cancer navigators had to know about resources, medical, social, financial, and then communications. How do you communicate what a cancer navigator is to a Pacific Islander patient? And then maintaining confidentiality. In nearly every study I've done in Pacific Islander communities, the confidentiality piece is probably the major concern that emerges about the research process, interestingly. So what did they do? Well, by 2015, they had trained 211 navigators in Hawaii. One study found that each navigator provided about 6 actions per case. This led to improved timeliness. Patients were more likely to start and even complete their cancer care when they had a cancer navigator, because the navigator was able to coordinate their appointments, arrange services, and even provide important emotional support. And then this increased patient sense of control and confidence. Let me see in the chat. Yes, Papa Wakahi is awesome. Okay, perfect. And then this is from their website. These are some of their cohorts of cancer navigators. Another success story I really want to highlight is actually now more specific to Southern California. It's called WingCart. This was led by Dr. Sora Tanjasiri. This was a larger program that was funded by the National Cancer Institute in 2005. And to lead this basically center, it was guided by both a Pacific Islander Advisory Board and then a scientific board. So they had 2 boards, really interesting approach to CVPR. And they focused on 5 Southern California populations: Native Hawaiians, Samoans, Tongans, Chamorro, and Marshallese. And the mission of WingCart was to reduce cancer health disparities by doing 4 things. First was create a partnership network of Pacific Islander health organizations and researchers, which did not really exist prior to 2005. Increase cancer awareness and reduce smoking in Pacific Islander communities. Fund and develop research grants around cancer for Pacific Islanders. And then this one, I think, is something I've seen hugely successful come from WINCART, is create leadership and training opportunities for Native Hawaiian Pacific Islander researchers. And so many students were really trained through WINCART. So what did WINCART do? Well, in just 2 years, partners were able to hold over 223 events for Pacific Islanders in Southern California. And actually, I know a number of people on this call were part of the WINCART thing. So thank you, for your partnership on that. They educated almost 30,000 people on a variety of cancer-related topics. And the partners obtained over $300,000 in cancer control grants. And then also multiple interventions and programs were developed. There were about 4. One was Let's Move. The other was the first online smoking cessation program for Pacific Islander communities. There was the Kane group for men's health, and then Non-Menace Mammogram, which is really great. It was a 8-minute play that was intended to increase cancer screening and awareness in Pacific Islander communities. So the next piece I want to talk about is more focused on just tobacco itself. So tobacco is something that's really prominent in Pacific Islander communities, but hasn't really been studied or addressed as much as I think needs to be done. In the 1990s, Dr. Tanjasiri and Rod Liu, they published a paper that found that about 42 to 58% of Pacific Islander men ever used tobacco, and up to 67% of Pacific Islander women had used tobacco, but this was about 30 years ago. 25 years of CDC data that we looked at for Pacific Islander youth found that they had about the 3rd highest smoking rates of any racial ethnic group in the US across 25 years of looking at high schoolers, basically, from the federal government data. Then in more recent surveys that my team has done, in 2019 data with Pacific Islander young adults 18 to 30 years, 52% of young adults regularly smoke. That's a massive number of people, and 20% screen positive for tobacco use disorder. And then when we looked at what are the smoking rates during COVID-19, we looked across about over 300 surveys in 5 states, and 31% of Pacific Islander adults reported lifetime smoking, but this number was the one that's astonishing. 22% reported current smoking during the COVID-19 pandemic. And this is much greater than the 14% US general population rate of current smoking, and is about matches the 23% smoking rate for Indigenous American, Indian, Alaskan Native populations, which is been known to be the #1 group that smokes basically in the US. And so our data is suggesting that Pacific Islanders may actually be matching that. They may be among the highest smokers in the entire nation when it comes to smoking. So the last kind of success story I want to talk about, I just think this is very fascinating. It's by one of my colleagues, Dr. Okamoto at Hawaii Pacific University. It's called Ho'ouna Pono. And this was a culturally grounded school-based curriculum for preventing substance use, including marijuana, tobacco use in Native Hawaiian youth. And they designed it using, again, a CBPR approach. They did focus groups first with boys and girls to identify situations where they were being basically pressured to use tobacco, marijuana, things like that. Then the team conducted surveys to assess exactly what were the specific pressures they were getting. And then they conducted workshops to assess how do we train or educate boys and girls to actually refuse when they're offered, when they're pressured to use tobacco, marijuana, alcohol. And so what resulted was this great 9-lesson curriculum. But what I really like about it is that it used these brief video vignettes of Hawaiian youth facing realistic drug offers in order to build their resistance skills to drug offers. And the reason, let me see if I can show this, is I just want to show a little clip of this because I think it's just fantastic. Hopefully people can see this. So this is a girl who is being pressured. This one is more about marijuana. They're actually developing a tobacco video now, and e-cigarette.
Cora.
What? Soapin.
What's up, Cora?
Sup, bro?
Yeah, no tell mom, okay?
That's my what?
You're not in elementary school anymore, so I was thinking you like to smoke and joint.
What? I never know you burn.
Bro, Cora, everybody in high school burns. I was thinking we're better trying what you brought out than with somebody else. You know what I mean? Come on, try 'em. It's good fun. You can play video games after.
Okay. Oh, hold on. Sorry
Come on,
about
try
that.
'em. It's good fun. You can play video.
Okay, so now we're back. All right, what's great about this is they did pilot studies that found that youth who received Ho'oponopono maintained use of their drug-resistant strategies. And especially what it led to when they did the full randomized controlled trial was it decreased cigarette, e-cigarette, and hard drug use. So it really seemed to work around this triggering tobacco. The reason I really want to highlight it is one of the lessons that I've seen so far in my work, many other people's work, is with Native Hawaiian Pacific Islander communities and patients, narrative interventions. These are storytelling interventions appear to be the ideal choice. And when we've done these panels to actually ask what do Pacific Islander people want from their cancer, tobacco, substance use interventions, it's narrative interventions. More broadly, though, we need to be engaging Pacific Islander communities at every stage of developing any type of program around cancer and tobacco, because this increases the likelihood that the interventions will ultimately be accepted by the community and by patients, and then be more effective as a result of that. There are certain steps that it looks like the best research I've seen with Pacific Islander communities has first done is problem identification. You partner with communities to identify what are the problems around cancer and tobacco that are affecting them. Then what are the root causes of these problems? Because this helps us figure out where and how to intervene, especially someone like me who's not of a particular community, not from a location, for instance, when I'm going there, and then create the best strategies to address these problems, which need to be culturally responsive. And then I have a little chart here of things that people can do. But I think everyone can just look at this for the PowerPoint because I'm really eager to kind of look and talk about the discussion that people have. Okay, so thank you. All right.
Well, thank you both for such a great presentation. You really kind of hit on the head on different points. We're going to open it up to the question and answer piece and discussion. We've had a few good questions come in during the middle of the presentation, so I've been taking note. First question is kind of directed at Dr. Tsoh, but I think both of you can answer. Was looking at, so when we were talking about lung cancer among non-smokers, do we think it's more because of secondhand smoke exposure and less smoke-free protections? Or do you have a separate explanation for explaining what those increased rates are in women who are non-smokers?
Excellent questions. And actually, that's what we used to think. And it's true. Secondhand smoke does get to, non-smokers lung cancer for both men and women. And this is a big question. So there's a big study. Like I would put a plug for my colleague, Dr. Scarlett Lynn Gomez. Their team is actually doing a big study, inviting women with or without cancer to participate who are never smoker to really understand what are the factors that would be involved. And actually, I will put it on the chat in terms of their study website, but it's still not known. But yes, secondhand smoke could be one of them, but that did not explain it all. Yeah.
Thank you. The other question was concerning how does family education work when a lot of times the family is not able to attend appointments with patients? Do you look at handout giveaways? Do you do follow-up calls? What is the answer to this piece?
Another excellent questions. I mean, definitely the challenge being is like, are we able to get family member? Are we going to get, for example, for our research with smokers and a family member is like, can we get them both to come in? Certainly in our process of doing this research, we required them to come in, it's like, if you want to enroll, like come in. But I would say that it really takes some, some effort to actually even just by coordination. Our most recent pilot done with Korean communities, we have done it by Zoom. So make it more feasible. And it's kind of interesting, even that they may be in the same house at the same time, they may actually ended up showing up in two different screens. One's holding the baby, the other one, doing something else, it's like two separate Zoom screens. But talking about, how does it work, when we don't have a family member, or they're not able to come, I think we need to be flexible, to be able to say, hey, even one of you come to learn. But I want to emphasize, if we're able to, I'm not saying that one size fits all, and also even social support, family, the definition of family can be very loose as well, someone's support in your life. But sometimes people may not have that adequate support. So we have to have something, available, navigator support, for example. But for people who are able to, and if we have this opportunity to offer, it is very powerful, particularly when at least two people, we're talking about dyadic, situation, when two people come and they learn about the same thing together, that actually increase the credibility of one person saying to the other, hey, did you hear what the doctor say or what the lay health worker said? And then importantly, we are creating these moments, these space for people to actually have an opportunity to discuss. They don't necessarily talk about it at home themselves. They're just so busy, they're too busy. And in fact, particularly with tobacco, in our qualitative research interviews, we have learned from these families is that we have this nice paper done by Annie Barrett Peterson, our our doctoral student at the time, and now she's an assistant professor in Loma Linda University, where we named the paper as Suffering in Silence. Families talk about various things, but when it comes to tobacco, oftentimes it creates so much conflict. Not only the family, the non-smoking members suffer, but also the smoker, they feel stigmatized, they feel not included, and they ended up not talking about it anymore. Smokers still smoking, family still like, it's like no hope. Hey, but we get them together in this kind of setting, giving them the right people, right ingredient, right moment. We actually get them to talk and work together. So I just want to, share with you some of our exciting moments, but it's not easy work at all. So thanks for the great question. So I'm going to put the study site about the lung cancer with the study on lung cancer with non-smoker up in the chat for everybody.
Yeah, do you have any comments, Dr. Subica, on the family interactions?
Honestly, Dr. Tsoh did such a good job. No, I'll leave it with that for sure.
Okay.
Though there's a cool question about tobacco industry, which I know is pretty important to appeal. So I'm actually curious to hear what Dr. Tsoh thinks, and I definitely have some thoughts about that one.
Sure, let me go ahead and ask that one. So it's the role of tobacco industry, there's higher rates of use and morbidity and mortality that you have both described in some of the Asian American Pacific Islander communities, including what industry is up to in their countries of origin for immigrant communities. So in talking about this, how is the industry targeting communities a message that resonates, and how do you think it would be received by various communities?
Yeah. Dr. Tsoh, do you want me to go first, or?
Please do, yeah.
Well, it's a great question. The reason I like this, well, first, I know the executive director of Appeal, Ra Lu, has written about this before, the kind of targeted marketing for Asian American Pacific Islander communities. It's definitely there. One of the things I would say is it's nearly every community of color appears to have kind of this disproportionate marketing, and it's really savvy. And the problem is it really works. So the question is, you're wondering, it looks like it works really well. There's a new study going on around e-cigarettes. So e-cigarette uses in Hawaii, at least, Pacific Islander, Native Hawaiians have the highest rates of e-cigarette use in the state. And I think it looks like maybe nationally even. So I showed that Ho'oponopono, they're trying to develop now this e-cigarette videos because it's such an urgent problem around this. And the way that they're doing this and is working, and including for cigarettes, is flavors. right? The flavors are really attractive. They're really hitting it. So what places that are really smart, like California, are starting to doing these menthol bans, these flavor bans, and they do seem like they're probably going to be the ticket. I mean, even tobacco taxes work incredibly well. So these policy levers that we might be able to kind of push elected officials to move probably could do a really great job, more than kind of any specific community intervention, in actually kind of stopping this targeted marketing that, cigarette smoking was dropping for a while among youth. And now e-cigarette has exploded among youth. And then it looks like smoking might be kind of this bridge now that's starting to increase. And that's a real problem, because anyone who starts smoking before 13, I think the rates are something like 60 to 70% will become, lifelong smokers. So trying to stop that, especially early on with the marketing, is such a good question. Yeah. And then I turn to Dr. Tsoh.
Hey, thank you, Dr. Subica. You have done such an awesome job in responding to this question. I think the only thing that I will add, just from my perspective, like kind of like thinking, is our team is constantly thinking about, designing intervention and all that. One of the things that we haven't done, and we wanted to include and would love to have more insights, sort of the best way to include, and I think Rod would be our go-to person at Appeal as well, is to include this part of actually revealing these dark secrets from the industry to let our community know, particularly as incorporated in part of these educations, and really to mobilize, like saying that, we are actually being fooled all this time, and look at who's like earning the biggest, biggest sum of money there, out there, and it's like conspiracy, that's going on. I think if we do it right, time it right, this could be, this has potential, like a powerful tool. But also I'm thinking, because like part of our work is talking about family education, we have not had an opportunity in our work, and I really wanted to look for collaborators who have experience doing this, is we can involve the whole family, including the younger population. That is so important when it comes to talking about prevention and early cessation. Even if they started, if we get them quit early, is so important. So I think addressing this is important. But I have to admit that in our community-based education, we have not yet included this component, which I would love to hear more ideas.
Sorry, I was mute. Great answer. So we've had a couple questions come in based off of your answers. So I just wanted to, before we move on from this topic to a different one, what about menthol use among AANH and PI populations? And also, do you have links to studies on the tobacco use as well as e-cigarettes among Pacific Island use?
Yeah, I can't really speak to the menthol use among Native Hawaiian Pacific Islanders. I'm not entirely sure. There have been some studies on that. Again, the research is just so minimal, unfortunately, for Pacific Islander communities. The link, so a lot of this work comes from a gentleman named Paul Pockrell at University of Hawaii Cancer Center. He's done a ton of work. I can probably send out some links. This is definitely in the research that he's kind of been doing for the past few years out there. So yeah, so Dr. Pockrell definitely has been kind of driving these studies, but I'm not exactly sure how much he's published of this specific Pacific Islander. So yeah, but I'll try and look and send some.
Yeah, for the Asian American, particularly with menthol use, I have seen some data, but they are mostly for English speakers, particularly in the national survey. So that actually speaks to some of the gaps. I have to say, when I started my career focusing on smoking cessation in Asian American, is that I actually asked my first study with Chinese smokers. I asked menthol use because I'm really curious about what they say. It's actually interesting. Just speaking, from what I learned in some of the advertisement in Chinese in China about tobacco, they actually say, oh, we have like ginseng in this tobacco. We have like some good stuff in this. So this is actually good for you, that kind of scenario. And for menthol, I have had qualitative data when I interview some of our smokers. They talked about they actually feel that it's like a cleansing cessation. So it sounded as if there was like a favorable direction toward picking up menthol. But when I start asking, when I doing my first study, asking a couple hundreds of people in terms of their use, among other items, I did not get a sense that it was like hugely popular, it was being used, but how that is related to cessation. We learn from a lot of important community data, particularly among Black smokers. We know they are highly addictive, more, actually becoming like a barrier for cessation. But I have to say, I would love to hear from any of you who have additional data, that you're collecting, that you'd like to share, and I think as Dr. Subica mentioned about cigarette, menthol and other, flavors. And I think, we give a kudos to our state, to, our counties, with the banning, with the policy change at the same time. So I think it's just this is something that I would love to learn more about as well.
Great. So let's see, another question comes in that's about Asian men that are born in foreign countries are not interested in having conversations about quitting tobacco use in this person's experience. Are there any studies that have a qualitative approach to explain why Asian men in particular are reluctant to receive such resources for quitting?
There are a lot of, maybe I will jump in first, Andy, if you won't mind. Okay, so there are some qualitative studies that we have seen in, like, for example, in Korean communities and all that, that talk about, their perspectives, smokers' perspectives of quitting, and in some of our work as well. So I could share with you some, kind of just examples. That's what I learned, actually personal experience in terms of I interviewed some smokers like a long time ago. One of the Chinese smoker shared with me, and he said, coming to America is actually really making it really hard to smoke, actually, with all the policy and all that. But you got to think about it, and certainly there are a lot of studies talking about similar, is sort of image, masculinity. And also it's highly acceptable for men to smoke. It's like a social thing. And this smoker further shared, when I meet somebody, I have several different brand of cigarettes. I will see in terms of what social class they seem to be, and I will share the appropriate, like, the kind of them. And similarly, he got a similar reception. So it's a social things, but importantly, particularly with this individual, he said that, I grew up, in 3 generations. My grandfather's, grandparents are tobacco farmer, supported by the government. And my father smoked, and I smoked when I was a little kid. And if I don't do it, it's like as if I'm dishonoring my family. So there are certain cultural issues. But going back to how can we, support these people? One of the interesting findings that we found, haven't published yet because it's somewhat, the latest, is that we noticed when we did our study, we choose our experimental and control group. Experimental sounds like weird term. So our intervention is focusing on tobacco, and our comparison group is focusing on healthy living and physical activity recommendations. Guess what we found? Let's see if I can have a slide that I can verbally describe. The latest finding we got, we followed people for 12 months. Okay, so they all have the same lay health worker curriculum. It's just the focus is different, but everybody got the handouts, okay, on all 3 topics, nutrition, physical activity, and tobacco. What we found was for people who were not doing anything, like they were not health conscious, they were not eating healthily, they were not doing physical active, when they receive the healthy living curriculum, just saying that, focusing on healthy living, focusing on physical activity and all that, they quit at the rate of 40%. 1 year later, verified by family and celebrity continent, as compared to, roughly around like, for compared to those who were more health conscious, they already do well, 17% in that group. As if like, if they're already health conscious and we're still telling them about physical activity and nutrition guidelines, they say, oh, I'm already good. I don't quite need to quit smoking. So one of the suggestions, one of the things that we've learned is that, maybe we don't need to start with quitting. We can start with promoting health. Smokers care about their health. They care about their family health. Something for us to consider. Dr. Subica, you're so sorry, I'm taking a long time.
No, I mean, I thought that was a fantastic response. I guess, well, if I were just really quickly look at the menthol thing, I guess, yeah, I'm jumping to the other one because Dr. So you answered that one really well. The one thing I want to point out is what's interesting is the FDA said last year they were going to ban like menthol. They were going to do these things. And then now it looks like they've been trying to roll out rules. But, I guess I want to just go back to the policy point is what people say they're going to do and then what actually happens can be different things. It can take decades. FDA has known for a decade and been concerned about menthol cigarettes hooking young people because it's milder, right? And have done nothing about it. And they say they are, and they're not sure. And that's why the panelists on this call appeal is just so important. Because without people pushing this, using the research that Dr. Tsoh is developing type of thing, I don't know where we're really at as far as community impact. So I like the idea of menthol, but I want to point it out as just something we know that we need to do something about, the government knows, and still nothing has happened yet. Right. And that just, it feels like capitalism ultimately at this point. Yeah.
Honestly, it is capitalism. That's really, the part that's moving everything. We do have a question about familial influence as an education force. This is a question for both of you. What are the strategies beyond traditional methods such as quit lines and screening that you think would work with AA and NHPI populations, even those that are specific to like a nationality or a culture that aren't being typically funded by medical research or public health programs to better address issues for these populations? So this kind of, is looking at out of the box things that we don't normally take a look at for funding opportunities and what you think would work to help with the, I guess, moving the populations to either, smoking cessation or cancer prevention.
Dr. Subica, you want to go first? Particularly about, the NHPI populations.
Yeah, sorry, I was looking at the question, now I lost it. I'm not sure where is it, Michelle, because I just want to make sure I'm totally answering it.
Okay.
Okay, yeah, I see it.
You can find it? Okay.
Yeah. Okay, so this is a really, really good question.
So sorry. Are we like?
I was just gonna say.
Go ahead.
Go, Janice.
No. I was thinking, more like conversation mode, and everyone please chime in as well. I was
That's
thinking,
exactly what I was about to say. Yeah.
I'm thinking out loud here. It's like, are we like kind of thinking about sort of additional traditional strategies, right? We know to go to, for example, go to see a doctor, talk to your doctor, go to talk to, quit line, right? And then this great question is asking, can we go beyond that? Like, what else can we do? So one thought I immediately thought that, we always need to approach these things with multiple strategies. It takes a village. I don't think just sending someone to the doctor would even necessarily help. Coming home with families or with friends, those influence, we know that like with tobacco use or any like required behavioral, change, and even screening, someone may need to further encourage or to even navigate the complexity of any health system, even making appointments. So I feel that we're talking about multi-level support. And also recognizing that there are moments for tobacco, particularly, if you may agree, that smokers' motivation, ambivalence change, really changes quickly over time. So sometimes is the moment, teachable moment, for example, and I also have spoken with people when they say, so how was your journey like? How did you change? And say, I just quit. Like, what makes you do that? To some, it could be as just like a strong moment of realization, like really knowing someone who died of tobacco-related disease, for example, like having this like really this dramatic personal moment. I'm babbling here, and so please chime in.
No, I really like that. I like that perspective. So I guess the reason I was pausing here is I think it's a great question. And so I'll go in a slightly different direction because I'm a health disparities researcher, which means I'm really concerned about social determinants of health, kind of what are the root causes. And the thing that kept popping up in my work with both Asian Americans and Pacific Islanders that just wasn't represented in the research, in the interventions, is cultural trauma. This historical trauma, basically racism, discrimination, the stuff we're seeing with Stop AAPI Hate right now, which is impacting both Asian Americans and Pacific Islanders. But I do want to just raise this thing because I was really troubled by this lack of just talking about cultural trauma. So I actually worked with a colleague. We published a new model this past year, but the thing that spurred it is this belief that I now have by talking to indigenous communities, Asian American communities, that when these groups come to America, even when they settle their 4th generation, 5th generation, they're still seen right as other. They're still the perpetual foreigner, and they're treated that way. And what happens is the culture is denigrated, it's lost, it's attacked. You can see this with Native Hawaiian populations, right? I was talking about some of this type of stuff. And so if we're really going out of the box, what's driving cancer, obesity, diabetes? I've heard from, let's say, Maori individuals, it's the fact that there's something toxic and deeply damaging and wounding about having your culture ripped from you, having, the things that make your life and your social connections so fundamental, right? The fabric of your life, just be discriminated against is damaging. And I think it's damaging on a biological level. I think we're seeing a lot of things around epigenetics for Holocaust survivors, like really interesting stuff popping up about. So what can we really do if we're talking non-traditional? It's uplifting communities, right? It's restoring culture. There's a lot of good cultural resilience, restoration interventions that I think we need to start looking at a little bit more. And I think that will uplift all disparities, because the thing about disparities is they're interconnected, right? Because poverty, healthcare access is not driving cancer, it's also driving obesity, diabetes, right? So you can't think of one disparity, cancer and tobacco, and not think of alcohol, mental health, anything like that. So I think we need to start also diving deeper. And I think it really impacts Asian Americans too. They're some of the most discriminated communities. We don't talk about Japanese being in concentration camps, things like that during World War II, but it was real. The Page Act against Chinese Americans, right? We have a history of this. So I think that's kind of a thing I'd like to see the research going towards now, is also addressing the multi-level and this deeper social kind of intervention. Yeah. So
Well,
that's
this is so
definitely my
excellent.
soapbox. Yeah.
This is so excellent, Andy. I'm so glad you bring this up. May I chime in a little bit here? When you're talking about the social trauma, the discrimination, the history, I think this is very, very common. It's not only with immigrants, but it's multi-generational, as you mentioned. That is so true. And one of the things that in some of our pandemic work with COVID, I got the privilege to work with a couple of really great group where we are able to ask some questions of discrimination and also tobacco use as an example. We are seeing those people indicated, being discriminated, particularly having this long-term discrimination, they were more likely to report they are using tobacco, but certainly, also commonly, for example, including alcohol as well, and for some younger population, including marijuana as well, in terms of coping with some of the pandemic-related stress. And you're talking about how these long-term trauma could be related to epigenetics and all that. So recently, I've been reading up on telomere length, sort of as a sign of these chronic stress as a result of like premature aging. And I think, I would like to really see, when I search telomere aging, I don't see very much out there at all, on this topic. So thank you for bringing it up, Dr. Subica. I think you were taking us to, thinking really to the next step, focusing on that. Completely agree.
Great answers from both of you. I wanted to follow up with a separate question that was sent in. Is there a way to really define cultural humility and cultural competency in terms of, there's a lot of people who are really interested and passionate in this type of work, but they have no idea how to really develop and nurture the relationships that lead to trust and self-efficacy as it relates to prevention or early detection of chronic disease. So,
yeah, I'll definitely defer to Dr. Tsoh on that one. Yeah.
I would like to involve the audience, when it comes of that, how
that would be
people feel free to chat. I don't know, Michelle, if this could open up for people who would like to share their thoughts, in terms of how do we move forward, what are some of the, if we imagine, maybe we can do, people could type in the word that they come to mind when we're talking about cultural humility, when we talk about respect. Maybe what word do you come to mind? What perhaps is it openness? Is that acceptance? Is that, please share, caring, curiosity.
Yeah, those are good.
Relationship building and trust.
Absolutely. Empathy, yeah. Tolerance.
We have, let's see, someone has raised their hand. Tolerance, discovery, acceptance, engaging with communities early, intentional, an ability to listen and be supportive, active listening.
Yeah. And self-awareness too. We all have could be biased. Yeah, unbiased, right.
Breaking political, cultural barriers, cultural preservation, transparency. Suniva Driggers, do you have a question?
No.
Okay.
All I wanted is to let you guys know the presentation is really good, but it's so hard for me to understand and see all that unless I have a paper to look at it. But all of those information are valid, and also the data that you presented, both of you, I wondered where all those data come from. I know some from the data bank but those are some of the issues and things I'm concerned of, where the data are taken from. The other part of my, we talk about all this, but basically, what do? I think you touch on the cessation part of it, but that's the part because a lot of people that are immigrants and they don't have insurance under the United States, local insurance, state insurance, and those are the people that make the system kind of fall in the crack, and there are many of them. And my concern is how we can focus in helping these people, like treatment, allow them to participate or have access to patches, things like that, because they don't have insurance. So those are all issues we have to consider in the community. And besides, you guys are up there, but I'm down here. I'm in the local level of seeing people, but you are doing your work according to reports and stuff up there. So that's why my difficulty in serving the community is so bombarded with all data and things that are put in front of us. But I'm talking about a person that is in the community, local service in the community, seeing the actual people. That's me. And that's where do I fit? I know all those are knowledge we need, but it boils down to how to do the work. So the other part I wanted to mention is we keep going in circle. What I meant by that, we keep saying we repeat the history, and that's not good. For me, I don't want to repeat history. I want the history to move forward. But for me, I just can't take it when people keep saying what happened many years ago. Yeah, it's good to look back to those, but we have to move forward, because we keep going in circle. That's not that, we don't solve things that way. So I'm sorry,
Okay.
but I
appreciate your question. So I guess the question would be how to really move forward.
I mean, I guess I'll step in. Thank you, Siniva, for honestly for saying that. It's true. And you know, one of the challenges of research historically has been, right, they come into the community, take the data, do this stuff, the grant expires and they're gone, right? They call it kind of helicopter research or anything. You know, one of the biggest things, I guess I can just speak for when I was doing this work, is it's got to be with communities, right? It's got to be with, you know, Samoan National Nurses Association, Office of Samoan Affairs, you know, Arkansas Coalition of Marshallese. Like, I can't imagine trying to do this research without actually working through the community. It just wouldn't work for people like you. The challenge then, I would say, for at least what I've seen for Pacific Islander research, is it is a circle because there's not been the investment that needs to be done to actually move things. There hasn't been enough funding. And part of the reason for that, when I talk to communities, is there's not enough data. Like at least the Pacific Islander health research is just so not existent, even in these large data sets you were talking about, that it's hard to advocate for funding and get more attention. And I think, you know, everyone needs to be doing a better job. That's kind of what I'll say. If we're moving forward, though, I would like to see, you know, most research with at least Pacific Islander communities be CBPR, be working with, you know, people who have expertise and grounded knowledge like you, directing it, before you actually jumped on, the one thing I was going to say about cultural humility is I have a true belief that it's non-hierarchical. Like everybody's on the same level if you're really practicing cultural humility, right? It's not me and Dr. Tsoh here and everyone else from the community here. It really has to be here. Or I'll be honest, in my work, it's here. You know, I'm kind of taking my cues from what the communities are saying they need to pursue, whether it's alcohol, opioid, COVID-19, or now tobacco type of thing, right? The community decides, and then I just kind of try and help. I'm almost like a TA person to get like the funding and things like that. And I think that's my sense of what cultural humility is. If you're trying to move forward, is flipping it from this to this, and then kind of just enacting that as much as possible. So that's my like quick moving forward of what I think we need to be doing more of in the research field.
Yeah, thank you. And thanks again, Zenivia, for sharing these important points. One other thing you had mentioned, you questioned about where the data coming from multiple sources, and many of them are from population-based survey, including, we mentioned about CHIS a lot because we're in California. The California Health Interview Survey is available publicly. You can also go online to take a look. It's an annual survey, it's multiple languages, and by far it remains the largest, I believe, the largest population-based data that enable some disaggregation data of the Asian American. I believe their Pacific Islander data are much less as well, but at least for some major groups of Asian Americans there. Yeah, so as an example, but certainly, you know, many of those data, they do have some disadvantages where the survey were done with English speakers, but also there are data from electronic health records, but also that link to the point where you mentioned about a lot of people may not be seeking health care at the same time, so we miss some people. So it's not perfect, and I completely agree, we need to move forward, but we learn from the past. At the same time, I'm so glad Dr. Subica mentioned about the importance of CPPR. You know, it's really, you are the one who drive and letting us know as researcher, as your partner, as, you know, if I like see myself as the academic side, is we want to learn what's the most important thing, and also what are the venues, what are the gaps, including, for example, access to certain resources such as nicotine patches and all that. And so there have been some studies actually done, okay, if we give away free patches, will that work? Unfortunately, some say yes, but there are still some said no. It depends on how you give it and when to give it and whom to give. But you're bringing up an important point about policy changes. You know, we need to route together, you know, community researcher and policymakers. We need resources. We need to fight. Some of you may know of a research, you know, led by Lan Down, not too long ago, published, and talking about, you know, for NIH, more than like almost 2 decades of funding. We have now 7%, you know, constituting the US population, but funding focusing on Asian health research from NIH, from the National Institute of Health. Guess how much that was included in the budget? 0.17%. So just another way that we have a lot of fighting to do, and we need to work together for that.
Excellent answers from both of you. I was going to make a quick announcement before asking one more question. So thanks everyone for joining us today. For those of you who have to jump off to anything else, I wanted to quickly share that we're going to drop, we'll be sending out an email for an evaluation survey. And so that's, your feedback really helps us plan future webinars and events. So please let us know how we're doing. You should be receiving an email shortly after today's webinar from Miss Linda Bosma. She's our evaluator. She's really great. She'll send you an invitation to complete the short survey. And this will help us evaluate how well we're doing. And please watch for this email from her. The evaluation is voluntary and confidential. We've also dropped you some resources in the chat, so you can take a look at those as needed. So last 2 questions. We have one related to stigma and what providers, health systems, clinics, health organizations can do to create a better environment for depopulation. And then the last one would be, in terms of tobacco and cancer policies, what sort of cultural nuances can we really look at to really prepare for pushing policies that are very supportive of our populations.
I'll let Dr. Tsoh, if you want to take the first crack at this one.
Okay, so maybe I will take the one that talking about cancer, just cancer and tobacco. I got the privilege to be involved in NCI initiatives called C3I. It's called the Cancer Center Cessation Initiative, where it funded more than 50 NCI cancer centers now in the country, and we are one of the awardees as well, where it really focusing on integrating tobacco cessation services, better connect, better reach to cancer patients and their family as well, to promote smoking cessation. So this is one of the example, but funding ends. And then how do we sustain? So sort of that, let me bring, bring up to come to this really good questions about, what do we do, and believe it or not, actually, one of the things that we haven't been done enough perhaps is not when we talk about community, and even for a lot of the research, we tend to be having generally healthy individuals participating. And we actually, one of the aspects is tobacco use, in fact, impacting a lot for cancer recovery and survivorship. And a lot of cancer patients, even though they were motivated and they quit smoking, stopped smoking successfully, some of them relapsed during the treatment and also post during survivorship. And that actually impacting on their recovery as well. So I think that makes me think of one of the important thing, and not to mention the work focusing on Asian American, Native Hawaiian, Pacific Islander, is very few out there. I couldn't even name, in terms of focusing on the cancer patient in this aspect. I don't know if I answered that part of the questions for the cancer related one. So Andy, you want to share your thoughts?
Yeah, I mean, I guess we're running out of time, so maybe
right.
I'll kind of address this. I guess maybe the main thing I'll just say is, I'm a researcher, academic. I don't know if I'm particularly good or not, but no matter what I do, even if I do an amazing job, I feel like I'm a very small cog in a wheel, right? And if we're trying to change things, it really, I think providing data, developing interventions, that's kind of a role that I can play, Dr. Tsoh can play in this. But, I'm frustrated by the fact that there's not more I can do to kind of actually sustainably reduce cancer, change tobacco, right, over the long term, like Dr. Tsoh was saying, when grants end. And that's why calls like this are so important, and people on the call are so important, because it really is organizations, whether they're, in a community or national like appeal, that is where I truly believe the power is. So I've written some studies on grassroots organizing, how much that can really change these root causes. And so I would encourage kind of everyone on the call to really but to recognize that it's y'all who really has the power. Right. It's by developing a coalition. Everyone here sat for an hour and a half on a call with me and Dr. So you care clearly. And I think you have power, and I would love to kind of partner and be affiliated with this, but I recognize I tell my communities, I'm probably the least important part in actually making action happen. And I would love to see action. versus, research, but research can inform action. And I think that's, where I feel my role ends. And then I would, love to work with communities to kind of take that next step. Yeah, so that's kind of my way of addressing Michelle's question.
Well, thank you both. So glad you're both able to join us for this hour and a half. And thank you to the audience for really taking the time out of your day to spend that time with us and to really ask your thought-provoking questions. It's a very interesting and deep dive into what we would like to look at. So we really appreciate all of you joining us today. Go ahead and fill out the survey when we send it later today. And we really appreciate your time. Dr. Tsoh, thank you so much. And Dr. Subica, this was really great. Really happy with the participation today.